Hello to everyone. I will represent the evaluation of surveillance system of hepatitis B and C in Albania during the period of 2013-2014. Some data related to viral hepatitis B and C in Albania. We are still an endemic country for viral hepatitis B. The prevalence of hepatitis B in general population is 7 to 90%, and for hepatitis C is 1 to 1.5%. The incidence of hepatitis B is increased during the 2013-2014 from 5.3 to 7.7 cases per 100,000 persons. The age group most affected for both types of viral hepatitis B and C is 25 to 44 years old. Men are more affected than women for both types of hepatitis, and those are data for 2014. So 64.4% for hepatitis B and 68.4% for hepatitis C. We have a mandatory vaccination of all infants against hepatitis B, which is instituted in 1994 onwards in Albania. And because of the high vaccination coverage of 95% in country, we have low number of cases with hepatitis B in the age group of 0 to 18 years old. Our surveillance system of viral hepatitis B is based on two major systems. The major disease-based surveillance system and the syndromic surveillance system. Also, we do surveys based on surveys on risk groups, which are biological surveillance of infectious agent in multiple transfusions person and biological behavior surveillance study, which are conducted every 2 years. The aim of the study was to evaluate the major disease-based surveillance system for viral hepatitis B and C over this period of time, and in particular the new case report form that we have included in this system. The objective were to evaluate the attribute of surveillance system, to identify the weak point of the system, and to make the relevant recommendation for improving it. As a method, we use the updated guidelines of the Center for Disease Control and Prevention regarding the performance of the surveillance system. Results, we don't evaluate all the attributes. We have quantitative and qualitative attributes, and we evaluated simplicity, flexibility, acceptability, stability, timeliness, and data quality. Simplicity. Our system is structured in 3 levels, this is the flow chart of the information, how it flows in 3 levels. The basal one, where the reporting cases, which are from the GPs, general practitioners in rural and urban area, from clinical, from the hospitals and public and private laboratories. The information is collected to the local level, which are the Directorate of Public Health in each district. We have 36 of them in all country. And then the information is collected to Institute of Public Health in the national level. And the information then is distributed to the Ministry of Health and to the public. The flexibility of a surveillance system is evaluated retrospectively, observing how the system has responded to this new case report form that we have included. Our surveillance system is paper-based, it is not electronic one. The case report form was changed and adopted, including additional data related to risk factor for both hepatitis. Are included data related to the type of laboratory, the method of testing, the education for each case patient. And then this new form is distributed in every directorate, hospitals, general practitioner, and laboratories. And since its distribution, it is used for reporting the cases. Related to data quality, Data quality reflects the completeness and the validity of data which are recorded from the case report form. And in this new case report form, we have 27 variables, and their completeness, there are variables that are completed, that have an improvement in completeness, and there are variables that are not improving. Their completeness is less than comparing 2 years. And this completeness is, the data quality is influenced by the simplicity of the surveillance form. And in overall, in 2 years, the completeness of the case report form is to 70%. Acceptability and stability. This new case report form is was most acceptable from the epidemiologists and from the clinicians and the laboratories. The system involves interviews, and some of the patients refuse to answer them, and this influences the completeness and the data quality. Our system is stable, and this is measured by the system computers operate full-time. The number of unscheduled outages and downtimes for the system computer are very low. If there is any problem, the person are very disponible to repair it. The system is paper-based, so all the information is collected in, in Institute of Public Health monthly. And it takes a month that the data are transferred, are entered, analyzed, and then every 3 months we do reports to feedback the information to all the stakeholders. The timeliness. The timeliness reflects the speed between the steps of the surveillance system, and from the basal level, it takes 1 to 3 days to distribute the information to the local level, which are the Directorate of Public Health. This is when we have sporadic cases. If we have an epidemic, the information from the basal level to the local one is transmitted within 24 hours. We have a monthly notification from the local to the national level if there is a sporadic, we have sporadic cases. The median time from the laboratory diagnosis to reporting is 0 days. So when it is diagnosed, the cases is it's within a day, within 24 hours reported. The weak points of the system. We have a lack of data from the second source. To calculate the sensitivity and PPV, we don't have data related to the second source, which are data from the regional hospitals. The use of rapid test increase, the rapid test as a method, as a laboratory method, is most used in our country, almost in the public and private laboratories, and this increased the false positivity of the results. In the case report form is not specified the incubation period, is not specified the outcome of the disease, the reason of testing, and the status of vaccination. We have lack in completing all the section of the reporting form. The system is paper-based, and not all the districts are reporting the cases. Anyway, the system is simple, stable, flexible, and most acceptable from the epidemiologists and not the labs and hospitals. The completeness and timeliness are adequate to detect outbreaks and to implement the preventive and control measures. Sensitivity at PPV could be calculated, ensuring the data. A web-based reporting system, enhanced laboratory testing, and training of staff is necessary to increase the quality, the efficiency, and the usefulness of the system. Recommendations for improving the system: we have to review and standardize the individual case reporting form. We have to train the medical staff regarding this case report form changes and the mode of reporting. We have to provide all the microbiological laboratories of the public health departments of district with necessary equipment and diagnostic kits. We have to train the new staff of laboratories with the new methods to access the private hospitals and laboratories in the reporting, in the mandatory reporting form. And the electronic medical record system is necessary. And I thank all my colleagues from the Department of Control of Infectious Diseases, in the Institute of Public Health, and then in every Directorate of Public Health in all districts.
Thank you very much for a very nice presentation and excellent timing as well. I really like these evaluations, and I open up the floor. Yes, Hamad.
Thank you for a nice presentation of the quality. Just a small two comment. When your presentation, you find the incidence last 2 years, they increased 5.5, 7.1. And your constat, you can take, when you use the rapid test, you have some false positive. Yeah. That's if it is linked or not, because however, you have the good coverage for rate for vaccination since 1994. This is the first comment. One slide, when you present the variable, the profession you put epidemiologist. Profession, the profession.
Profession?
Yes. Can you like, just because the epidemiologist, this is the...
No, the profession of the case patient, the education, let's say the profession of each patient. Epidemiologists and clinicians are those who report the cases, who complete the form.
Yes. No, because the variable, just can... Because I am some confusion for this. Thank you.
Yes, the person, yes. Yeah, yeah.
Yes.
Here.
Profession, epidemiologist, this is...
No, profession is the profession of each case.
Yes.
And the epidemiologist is who complete the form and report.
I confuse, this is the profession, can you have the disease? Thank you.
And then, yes, for increasing the incidence rate, we think that using the rapid test as a method of in laboratory, it is influenced this high number of cases of incidence, high rate. We have to improve it. This is the weak point of our system.
Yes.
Thank you for your presentation. Actually, I had two questions. One about, you talked about syndromic surveillance system, and I want to, it's interest for me, is it included in the surveillance system, and is it taking the data from such system into action? And the second was about the surveillance system itself, that you give feedback to the public, and what did you mean that the feedback is going to the public? And also, all the presentations had been presented today about surveillance system. None of these data is talked about the usage of the data for the action making, except on Egypt, and what is the action that had been done, and the evaluation of the action should be also at the surveillance system. Thank you.
Okay. The first question was about the syndromic surveillance system. The syndromic surveillance system is a weekly mandatory surveillance based in case of hepatitis in the syndromic jaundice, and is not part of this evaluation. The second, feedback to the public. In the Institute of Public Health, we do the reports every 3 months that is distributed to the Ministry of Health. And in the public, in the case that we have an outbreak, and the public is included, the media or the NGO organization or foreign embassies that they want to have an information related to the hepatitis, viral hepatitis B and C. And the third one, sorry.
About the usage of the data from the surveillance system into action, and the action itself, does it report it in the surveillance system also?
The action is reported to the
For
surveillance system.
all data has been collected in any surveillance system should be for data for action. Is the
Yes.
action is reported in the surveillance system, what action and the output of such action? Is it included in the surveillance system? And it's too difficult. You cannot answer. You cannot not answer. It's okay for me.
The action. So for each case, it's doing an epidemiologic investigation where all the data related to the patient is included in the case report form and is collected to the Institute of Public Health. So we do know what happens with all this information, and if there is any outbreak, so we know. Sorry. Yeah.
Yes. I just need to rephrase his question because I have the same question. You mentioned, okay, you mentioned something about sensitivity and the lack of the regional hospitals being reporting.
Yeah.
So this is, what have you done as an action to address this problem? This is my question, but I believe
Okay.
same question.
To calculate sensitivity and PPV, we need a second source of data. And the second source of data, we have it from all the regional hospitals. So in this period of time, we don't have such of data. It was impossible to collect it. And because of that, it was impossible to calculate it. And it takes some time, and it could be done, but need more time to do it.
Thank you. Yeah.
Okay, thank you for your presentation. I liked very much the way you presented the surveillance. I only have one question and one comment. My question was about the case definition. I would like to see your case definition because you have mentioned the rapid test. And I don't know if you are entering the positive rapid test into the surveillance system, which will make a huge amount of cases, which is not,
Yes.
I think it's not correct. I don't know your case definition.
The case definition includes clinical criteria and laboratory one. So a case with viral hepatitis is when he met the clinical criteria and confirmed by laboratory. But not all the cases are diagnosed using rapid tests. So we have ELISA in institute and in the private laboratories. So there are many cases that don't meet the criteria of the case definitions.
That's fine, because in Egypt sometimes we did the rapid test, but we don't take these cases. When they are positive, we did the ELISA, and
Yes.
when it is positive ELISA, it enters the surveillance system, but not with the rapid test. This is the point that I want to ask about. The other comment that in Egypt we found that hepatitis surveillance is not simple at all.
It's not?
And I am glad that you mentioned that your surveillance is simple, and maybe I want to talk with you about simplicity because it talks about several entities of diseases. It takes a long time for diagnosis. It needs a lot of diagnostic tests and so on. So in Egypt, we considered it not simple. So I'm glad that your system is simple. Thank you.
Thank you.
Thank you very much.